I think we're already live.
Yeah, I think we're live. It says streaming live.
Awesome. Hi, guys. Once again, Dr. Chellam and Marina from Holistic and Integrative Center of Novi. We have a very special guest. This is one of those podcasts, which I think most of you enjoy when I have a guest, because which means the knowledge is beyond what we have. And our special guest is Dr. Tara Scott. Tara, when we spoke the other day, you mentioned you're half Indian. So yeah. Tara would be pronounced as Tara, right? Yeah. Tara means star. So yes. You are the star of our podcast today. So why don't you introduce yourself to our audience?
Well, thank you. Actually, you're right. It's not Tara, it's Tara. But a lot of people call me Tara, but it's Tara, right? And it does mean star in Hindi. So yeah, so happy to be here. Thank you for reaching out. So excited to collaborate with people in the same space in functional medicine. It just, we connected on Monday. We could have talked for hours about things. So it was just really a nice connection. So
right.
My background is an OBGYN. I practiced for 20 years, delivering babies, doing surgeries, that kind of thing. And I've been in the functional medicine space for probably about over 10 years. It started first with natural therapies for menopause and hormones and PCOS. And then as I learned more, I learned how much I didn't know. And then I learned more.
Isn't that the truth?
Yeah, so I went on to get training in functional medicine, got a board in functional medicine, then integrative medicine. So my focus is basically women's health, and we connected on your women's issues. And because I've seen so much of women's health be affected by genetics, that's also been a passion of mine.
Awesome. And I've seen a lot of videos on genetics, but nobody can explain stuff and simplify it like you do. And that's why I thought, if I want to get my genetic profile really explained to me, you're the best person. And I think being in the functional medical space, we love to share, even though this is something I would consider very private. But one of the things I want to really let people understand is, as physicians, a lot of times people come to us thinking they have to make changes, they are ready to make changes, then they fall off track. And what they think, their assumption is a practice like ours will judge them that they're not doing the right thing, and that they did something. So one of the reasons I wanted to share this is to show people I'm as bad as they are. In many ways, right? And I don't want to feel like a hypocrite. I do have issues that I've needed to take care of for years, but I've taken care of bits and pieces of it because everything else was more important. So finally, this year was one of those things I said, I'm going to have to really delve to the root of all of the issues that I'm struggling with. And that's how the genetic or the genomic analysis came about. And so just to give people a background. So what we will do is we're going to share some slides so people have a better understanding of what we're talking. And that way you can take over, and don't mind me kind of asking you questions in between. That way, there's some clarity for both for me and people who are listening to this.
Sure. So, I guess I'll just tell you guys when to flip the slides then.
Are you able to see the slides at this point?
Oh, yeah, I can see them, but I just can't flip them. So I'll just tell you when to flip.
Yeah, we'll flip. Okay.
Perfect.
All right. So we called it the Genie and the Genes, right? And that's really what we're trying to see. So let's go to the second one is, why can you not do the slide? Yeah, so hang on from the beginning. Here we go. There we go. All right. So that's you and your family. That's actually a very beautiful family. And I don't know how you did with 3 kids and OB-GYN.
Yeah, so actually the one in the middle and the boy on the end are twins. So I did once and had every obstetrical complication with that, delivery, conception, everything. And so I'm half Indian, the other half is Puerto Rican. So this is my daughter's quinceañera, which is
very nice.
The party when she's 15. So that's my younger daughter in the middle.
Oh, that's beautiful.
Yes. And so you hit the nail on the head when you said, people come to us and they think we have it all together. Well, I have had very unbalanced hormones for a very long time. And that is obviously what prompted me to study more and more to try to fix myself. So you guys can switch to the next slide.
All right.
So just kind of genetics 101, we basically know that DNA is two strands of RNA, and it's connected by these base pairs. And there's basically 4 different base pairs in the human DNA: adenine, thymine, guanine, and cytosine. So I kind of thought it looked like a row of houses, you know, the brightly colored houses. It reminded me that each little house is like a different base pair. So there's different locations within a gene. So you can flip to the next slide. So what's important to remember is a lot of the genetics that we're doing now, or that you may see with people getting their 23andMe or some of these direct-to-consumer things, is really not the whole gene. The whole gene is like the whole street. And it's a SNP, which is a single nucleotide polymorphin. So that's one house. So if you think of a whole street of houses being the message or the Braille code that would translate and tell the cell what to do, one location, just one location, is what a SNP is. So unlike something like Down syndrome, which is a whole chromosome, an extra chromosome, or a whole piece of an extra chromosome duplicating at the 22nd spot, this is just one little area. So most of the time, the consequence is not as much. And that's why it's not like these people are sick when they have these. And it's not like this isn't something that we can overcome.
So just to talk about, like, when you say a chromosome, what would you liken a chromosome in terms of, is it the city or would it be the street?
Yes. Yeah, so I would probably say city or state for a chromosome. There's so many different locations within a chromosome that and they've actually mapped all those chromosomes off so that there's certain locations, which would be the cities. I guess you would say we have 23 chromosomes, so maybe 23 states, and each chromosome has a lot of different locations on them. Some are bigger than others. Yeah, that's a good
and then when you actually look at a SNP, it's one house that we're looking at in that city, in that state.
Yes, so that's a good scale, right?
Yeah. So for people to understand what a SNP is.
Right. So the other important thing of the SNPs are that it depends where it is. So for example, on this particular gene, you can actually have some regions that are coding, some that are regulatory, some that don't have anything to do with it. So if you have a SNP, that's, for example, the beginning, the top of that slide there, it says link slip outside of the gene. It might not have anything to do with it. So if you have one house that is on the corner that nobody lives there and something happens, nobody lives there, there's no significance. Whereas if you have something in the middle of the gene, which is the regulatory sequence, they might have more significance for having a change there, or more importantly, in the coding region. Because remember, all those ACTG, those base pairs, are like a language. That language translates to instructions, either to make a protein or to have an eye color that's blue or brown or to digest something.
Right. So what's the difference between a regulation and a code?
Well, so a regulatory is changing, you know, it's not a coding, it's changing the amount of protein in the case of a protein. So this would probably be pertinent for an enzyme, because for something like eye color, it's blue, brown, green. But if it's something, what we're talking about today a lot of your enzymes. And so that it changes the amount of protein, so it might be fast or slow. And then if you have it in the coding region, it's going to actually change the sequence, so it's going to maybe give a different message. So I think there's another slide in there that shows about how the shape, yes, the next one. Okay, so for example, in the person 1, they have an A at the 3rd position. And so with that code, that is like, think of it as your iPhone password, you know, something you type in and it opens up your iPhone, you know, your lock code. Person 2 has a T. And so at that, maybe that protein looks differently. It's a different shape, but it still functions. And in the case of proteins, a lot of times they bind a protein. So like a key fits in a lock. Sometimes you've had keys that fit in the lock, but don't turn it. And maybe do some things like your valet key might open your door or something, or maybe it turns on your car, but it doesn't open your glove box. Something that's a little bit different from that key. And then person 3 has a C there. So if you look over to the right, they have a complete distortion of the way the protein is. And so a good example of that is like sickle cell disease. We know that they have a difference in their hemoglobin, and that hemoglobin does a different job of carrying oxygen. So that's why people with sickle cell, people can have a trait where they just have an alteration, or they can actually have sickle cell disease. So that's the thing that's very confusing about genetics, is that there's so much we don't know and that we're still learning. We weren't even able to identify really what was normal in the human DNA till I think 2003. So it hasn't been very long. So,
yeah, it's been 20 years since they discovered, and we thought by now we would have the reason for diseases and we'd have the cure for all diseases, and we're still learning. And it's almost like lesson 101, even for people who do the research.
There's a lot we don't know, right?
Yeah,
right.
yeah.
This kind of, like I said, genetics 101. So if you go to the next slide, this is how I like to explain to patients. Let's just say you're coming to see me, and you think you're going to see Dr. Joy Scott, J-O-Y. But in walks a man, and his name is J Scott, J-A-Y. So one letter totally changed the meaning of that word. However, in this case, he's still a doctor, he's still a human, he can still help you. But one letter in that word totally changed the connotation of the word, although the end result isn't that big of a deal. So some of the SNPs we have are like that.
Right, right.
And then if I say, hey, are you two coming, or are you coming too? You both hear too. And you know what I mean when I say, are you two coming, T-O-O, or you two, T-W-O. But yet, so it's different. It's a different word, but you can still understand the meaning despite that difference. The other way I've heard it explained is you see a lot of genetic companies that are looking at ancestry. So I thought, hey, my ancestry is pretty straightforward. All my relatives are in India, or all of them are in Puerto Rico. So there shouldn't be really any confusion, right? But I still came up with small percentages of like Ashkenazi Jew, like less than 1%, African American, very, very strange. So what they're doing when they're giving you that ancestry report is they're looking at little changes in the gene that will tell you where you're from. So for example, when I teach in Australia, instead of saying estrogen, E-S-T, it's O-E-S. So they have a different spelling of estrogen, or color, C-O-L-O-U-R. So when you see certain words that are spelled a certain way, you can say, oh, that person's from Britain, or that person's from Australia, and then this person is from the States. So certain genetic changes just place you where you are geographically. So those are also things that are looked at in those tests. And then if you go to the next slide, there's some SNPs that, like the U into an A, if I say, did you cut that off? Did you cat that off? It doesn't make any sense at all. One letter in one word totally drastically changes the meaning. So there are some SNPs that are like that as well. So first of all, it depends on where in the gene it is, and it depends on the type of mutation it is.
Got it.
All right, so even to compound that, we know that we get one gene from your mother, one gene from your father, one copy. So you get 23 chromosomes, and that makes it. So you might have a SNP only on one copy. That would make you heterozygote. And we say that would mean you have one, I hate saying abnormal, maybe a variant copy.
Yes.
The correct term for normal is wild type. And to me, that didn't make sense, because wild seems like it would have the connotation that it's, abnormal. So wild is normal. Heterozygote means one abnormal copy, and homozygote means that you've gotten two. Now, this is what we usually say for a whole gene, but it rings true, the nomenclature, for most SNPs. Now, some SNPs, they don't want you to refer to like that, like the Comt, and we'll talk about that. They want to refer to Val or Val-Met. So, but for the most part, we say hetero or homo. And generally what that means is that hetero is not as serious, and we're talking about how slow an enzyme works. Hetero would be a milder form, and homo would be a more severe form. However, you have to know all the SNPs though, because some of them, the wild type, might be homozygous.
Yeah.
So abnormality. So it's very, very confusing, and it takes, I mean, I've been studying it for 4 or 5 years, and I still don't even know a scratch of it really that a genetic expert would know. So
totally. I think the more you learn, the less you know. But it's like a maze. It's like a maze as you get to know this. So here we're getting now into some very specific genetic polymorphisms, or mutations, or whatever you want to call it.
Yeah, so this is one that we see a lot and we test for a lot in the guise of hormonal abnormalities. And it's MTHFR, which is methylene tetrahydrofolate reductase. It's an enzyme that is involved in folate metabolism, but it also is peripherally involved in how you make your neurotransmitters. So sometimes people can have abnormalities of the MTHFR enzyme that affect anxiety. Sometimes it doesn't affect anxiety at all. And like I said, that genetic code, what is supposed to be normal is CC or AA. So if you have CT and so in this particular example, the 677 would be the house number, okay? Like if we're thinking of the street, you've got the MTHFR street that's in the city, and I don't even know what chromosome this is on, but 677, the address, usually it's a CC, but you can have CT or TT. So in my case, I know I'm TT, so I've got that red. Okay, in 1298, you can have AA, AC, or CC. Now, according to Dr. Ben Lynch, who is one of the world experts on this particular pathway, he says that you don't really see anybody in the red that has both, right? I actually have AC at 1298, so I have 3 out of 4, so I'm a very rare case. In words. Yeah, you never want to be a rare case, so.
At least in this, yeah. This is this actually has a significance, unlike a lot of those that don't have a significance.
Right, right. And so you might see quoted that if you have, the 677, that it's more of a cardiac risk factor because it affects homocysteine, which is a compound that if it's elevated, we've seen it associated with heart disease. And you might have also read that 1298 could maybe be more neuro symptoms, but that isn't really necessarily true. Everybody is, it's just fascinating. Everybody can have a different manifestation of this particular enzyme. And the other thing, we'll go, I think we're going over in the next slide.
Yeah.
The next thing I wanted to say is, so I always think of enzymes, specifically MTHFR, COMT, a lot of the ones we're going to go over today for you, as a highway. Okay, so this is a highway, where I live. Okay, so the picture on the left would be the highway potentially at 3 in the morning. I know it's late in that picture, but there's no traffic there, right? And then the picture on the upper right might be how it might look at rush hour at 8 a.m. And then actually the picture on the bottom left is how it looks now because there's major construction where I live downtown. So the thing about it is if you have a patient that you suspect an enzyme isn't working correctly, and in the case of your COMT, that's your detoxification or how you get rid of estrogen, is it really that it's coded to work that way? Or is the traffic there because of the time of day? Or is it because it snowed 10 inches? Or is it because there's construction? Mm-hmm. So you have a lot of other things that can also affect the genes. So when people start thinking about genes, they get hung up on, oh, I have this SNP, I need to take this. Oh, I have this, I need to take this. Right. And so there are some definite supplement recommendations that we make, but the whole overall, forest through the trees, you have to think about the whole thing. And that's why, we'll touch upon some of the things that you've chosen, not even knowing about your genetics. You made these correct lifestyle choices that have prevented you from having worse problems because of genetic makeup.
Yeah, I call it the intuition. You just work off what your body wants. You just listen. And a lot of times we don't. We just try to go with the flow. And sometimes you just have to step back. So because we're going to talk particularly about these methylation genes. So what is methylation?
So methylation, you might hear, is all the buzz right now, but all it is a chemical term, right? So methyl group is a carbon and 3 hydrogens. And the process is such that you have one compound over here, this carbon and 3 hydrogens will be taken off of one compound and onto another. Mm-hmm. But in the case of estrogen, when you have that methylation, it's the second step of detoxification. So for example, you've got estrogen floating around in your blood, okay? And then you have one step, that's phase 1 detoxification, that changes and it makes it more polar. And the second step of detoxification is methylation, which makes it go from the sticky blood into the urine and go out of your kidney, right? So it changes the chemical reaction. So it's kind of like you have to sweep your floor and then you have to mop it. If you just mop it and you push all the crumbs around, it's really going to clean it. Or if you sweep it and you leave everything right there, it's going to be dirtier than if you didn't sweep it. So there's a 2-step process. So in my world of women's health, you know, methylation has a lot to do with genetic expression. It's we have seen, and the literature has gone back and forth with this, but I will maintain that having problems with MTHFR and methylation can increase your risk of miscarriage. I did have a miscarriage myself before I knew about my genetic testing. Also has to do with conversion of food into energy. So some people might say they have fatigue or they have problems gaining weight, a lot with brain and muscle, and also with DNA repair. So DNA repair, you know, if you have a cell that needs to be repaired, and then what's supposed to happen to the cell is it's supposed to commit suicide if it's growing too much or it's not. So there's some people that think that even methylation, turning on and off genes, has to do with any cancer, let alone female cancers.
Right.
I said before, the MTHFR, if you look at the actual biochemical pathway, it's right next door to a pathway of the what we call tetrahydrobiopterin, which is where you make serotonin and dopamine. So if they're linked like a cogwheel and MTHFR is going slow, then it's going to slow down its neighbor and it can affect how you make your neurotransmitters. So it's going to affect your stress and relaxation response, your detoxification response, and then your immune response. As far as the cardiovascular function, the neighbor on the other side, not the neurotransmitter cycle, but the other one is the methyl cycle. And so that has to do with SAMe and homocysteine, and recycling of that. And so the literature has shown and what happened is they started, I think the first reports were a 6-month-old infant that had high homocysteine, had coronary artery disease. So you know the baby's not eating steak and butter and everything, so it's certainly not a cholesterol issue, but that was tied to a defect in the synthesis of homocysteine. So that baby had primary hyperhomocystinemia, and that's a complicated thing. So that's why we think now you probably check, you know, cardiovascular function, your homocysteine a lot in your patients.
Absolutely, because I call it the sticky protein. And I say if you have a sticky cholesterol, the little ap, S, and your sticky protein, you're really in trouble. So that's how I explain it to my patients. So here comes my result.
Okay, so before we go into your results, I have a couple questions. Were you having any symptoms? Do you want to share any symptoms that you had?
Sure. So let me tell you, in fact, I think that is the next slide. I'll put this up. Miscarriages. I've had 6 pregnancies. I have 2 live kids.
Okay. Wow. Yeah.
I had migraines from the age of 11. It runs in my family. Like my father's side, everybody has migraines. And when I really worked on the metabolic aspects, I've not had migraines now for 10 years. So remember, from age of 11 till my 40s, I had a lot of migraines. As far as these go, the high estrogen fibers, fortunately, that has not been an issue at all. I cannot tolerate oral contraceptives. Every time I went on it, within 6 months, I would get off of it.
Okay.
Hopefully, that's what I'm going to try and avoid.
Right.
And fatigue also has not been an issue lately. That's why I said, you know, a lot of it I have really taken care of, but I knew there was something that's missing. And what is not in all of this is actually the specific difficulty, the quick way that I gain weight and the difficulty I have losing weight when I have a focus of, you know, just staying healthy. And it's been an issue in the last probably a year and a half. And that's where it prompted me to say, hey, what else am I missing? So let's go back. Sorry, I went too fast. Let's go back to this.
Again, the test that you did is a great, great test. And so if you're a patient of Dr. Nisha's and you're watching, you definitely want to talk to her about getting this test done, because in my opinion, I've done, I don't know, 5 or 6 different genetic tests on myself, but I really like their estrogen profile, and I really like the board. It's very user friendly. But I also want to stress that the methylation equation is much, much more even than this. But this is
yes.
one of the more thorough ones. So the first gene that we see for Dr. Nisha is this COMT. And you can see that what's supposed to be, so she has AA and it's supposed to be a different allele. So this one is usually reported a little bit differently. We usually report it as Val-Met, and so you're Met-Met. So what that means is back to that highway with construction and add traffic.
Yeah.
So
no kidding.
If you had a 4-lane highway, you're down to 1 lane in rush hour. So it's interesting because to me, yeah, you're both of those two.
Both of those.
Yes.
Okay.
So interesting that you say when we talked, you thought maybe the migraines were familial, and I don't remember what your NOS is. I think you had a problem there. That's migraines. But COMT for me a lot of times is migraines, because around the time of puberty, think of it as a highway. That highway is supposed to get rid of dopamine, okay, and serotonin. And so then you have norepinephrine. So you've got these enzymes that are getting rid of your neurotransmitters, and then you get estrogen on that same pathway when you go through puberty. And boy, now you've got traffic, and now you've got a backup. So in my world, girls that start having migraines in puberty, I always seek COMT. And then so in your 40s, maybe you at that point, because you are a little young for menopause. So I think in your 40s, maybe you had lower estrogen. So maybe that and the combination of the lifestyle and diet changes that you did help that. But I see this in a lot of migraine patients, the COMT. So you have a 3-fold reduction of your enzymes. And so the great thing about this enzyme is I've seen a lot of response to what we call epigenetics. So this one is like the highway, but you can fix it. You can give it a detour. You can give it an alternate pathway. So this is something that is definitely something you want to identify, because there is treatment for this. And we have been able to follow women's urine estrogen metabolites from pre-treatment and post-treatment. I do this in all my breast cancer patients, and I've seen these levels go down with just supplement treatment and lifestyle, which is great. So
yeah, it's amazing, but I can't actually for this blame my parents, because it looks like I inherited both.
Yes, yes. And so you can see that it says key intervention, increasing soluble fiber, maintain the quality of dietary fat, losing weight, exercise. It says select nutrition. It doesn't say what, but yet usually what we recommend here is magnesium. Magnesium is a great nutrient here. Sometimes we tell people to take SAMe. And if you're not methyl sensitive, somebody like you might be methyl sensitive because your enzyme is so slow. So if we start giving you methyl groups and you start making more neurotransmitters, guess what? They can't go anywhere because the Comt is slow. So I don't.
I'm crazier than I am.
Yes, that's why I don't usually recommend that unless I know if the patient's tried it or not. Now the MTHFR, for the C677, which seems to be the more serious one, not that that's necessary. That one is good for you.
I do have the other variation, but I think I forgot to get that. So we went over the slides. These are all my symptoms except for a couple. Yes. And then you were talking about the detoxification pathways, right? So this is like my version. It looks like a chili pepper, but it's actually the liver. And what you were talking about, the phase 1 and the phase 2. So where you add the methyl group is when eventually it gets kicked out of the system. And you think my problem is in the second aspect, second pathway.
So phase 1, there are some of your genes that were tested in here. Phase 1 of estrogen metabolism is 1A1, 1B1,
right.
EA4, that would be phase 1, and that's usually there's 1A1, that's phase 1. This one is negative for you, no variant, meaning that it functions correctly. Now GSTP is phase 2, so usually the cytochromes are phase 1, and phase 2 depends on what it is. It could be methylation, it could be sulfation, it could be glucuronidation. So it could be any of those things in phase 2. But for estrogen, it's methylation, so it's Comt. So
got it. So I have actually, go ahead.
So for this one, glutathione S transferase, I explained to people that glutathione is like your big vacuum cleaner. It just goes in and detoxes everything. And if I had, if we had the diagram, I didn't give it to you because it's kind of scary and busy, of the methyl cycle, the folate cycle, the methyl cycle, then it goes to your sulfation through CBS, and then that's where you make glutathione. So thankfully for you that you didn't have a variant at this gene.
Absolutely. Actually, my tests also do that. Now, this is another one.
It was another glutathione S transferase. And so this is also involved in phase 2, as you can see, of xenobiotics, carcinogens. So this gene is usually read as absent or present. And so it's saying that you have a deletion. So we didn't really cover deletion in our SNPs at the beginning, but you can also have a deletion. So it's kind of like some genetic tests do spell check. But in the case of 2-TOO and TWO, they wouldn't get that, right? But if you had a deletion, you're just doing a spell check, not a grammar check, and you might miss that depending on which genetic company you use. So this is actually a deletion. So basically this says it's less enzyme activity, so less ability to detoxify. And especially, so this is something that you personally want to make sure your cleaning products, your makeup, everything else you use, you're not using harmful products, anything in your environment you're doing. And then most of my patients, when they have this, I usually recommend doing some kind of detox. I mean, you can do a medical food detox, or sometimes people just do 4 or 5 days on fruits and vegetables. I know that you have a really good diet, so sometimes they do that because there's a lot of toxins in our meat as well. So that's the xenobiotics and the extra hormones as well.
Right. I know I used to cook in plastic. I was one of those, typical residents come back, and whatever I buy the food and I would just stick it in the microwave, the vessel would melt into the food and I would just have it. So talk to me about xenobiotics. I have it. I'm loaded with it.
Yes, and you know what is, I haven't experienced this myself in my practice, but I've had a lot of other practitioners say that they just tell women to stop drinking bottled water, and they have increased their estrogen burden. I have my, my refillable water bottle and my reverse osmosis water that I drink out of. But some people have a lot of plastics, like you said.
Yeah, that's true. So go ahead.
This is just an overview of your detoxification genes that were on this particular test. So you can see the 1A1, there's 2 different SNPs. So remember, like 2 different houses on that same street. One of them you have a SNP of, one of them you don't. And then you have your glutathione SNPs. Those are the next 3. 2 of them you're fine. One of them is indeterminate because you have an absent. And then there's your NQ01 that you were also okay on that.
So I'm not that bad as yet.
Good stuff. You have some issues. You're an estrogen factory according to your genes.
Correct. But I can vouch for that.
Yeah.
So this is a little busy slide, but I thought it was pertinent to what we were, because most people, what do they think of when they have a problem? They go online, they research. And, one of the things that you told me is you cannot take these specialty supplements. That's not what is going to work for you. So, when they go around buying these supplements, even for us, there's a lot we have to get into before we decide what supplements people should be on. Do you want to just simplify this diagram for people, like how you determine?
This is just like the typical functional medicine approach, right? So, when I started getting into hormones 15 years ago, it was like prescribe, but it wasn't necessarily functional because I wasn't thinking about detoxification and the gut and this. So up at the top, you have specific specialty supplements. The DIM and the I3C, a lot of people do take that. It works on phase 1 of your detoxification. In your gene specifically, your 1A1 was already upregulated. So to give you more DIM and to push more estrogen down that pathway wouldn't necessarily help you.
Correct.
So the specific vitamins, those are the cofactors. So if you're a bakery and and I'm trying to support your business, I could give you flour, or I could give you a muffin pan, a bundt pan. With you having flour and cake batter, you can't make anything without the specific pan. So the vitamins are the cofactors that have to help those enzymes run. So a lot of those And here it does say folic acid. I want to make sure that we point out that's actually folate. Folic acid is synthetic, and a lot of the diagrams in the medical world haven't made that designation, but folate is what we would specifically suggest. So the 5-methyl-THF is a form of folate. And then lipoic acid is an antioxidant, and NAC, N-acetylcysteine, is a precursor to glutathione. As far as diet, you were telling me that you have a vegan diet and you crave cruciferous vegetables. So that's probably, that's going to help, obviously, not only from the fiber, but the extract from the cruciferous vegetables is going to stimulate your 1A1 and your phase 1. Your intestine, you have so many ways to detoxify. You have your urine, your skin, your liver, and your bowel. So bowel needs to be working to be able to detoxify. And as a matter of fact, one thing that boggled me when I actually learned it is that if you have dysbiosis, the gut makes more beta-glucuronidase, and you can excrete estrogen through the liver into the stool, and then those bacteria can take the estrogen out of your stool and give it back to you.
Yep.
Yes. So calcium D-glucaride helps bind up estrogen in the gut, and that's actually really well tolerated too. And so that's not phase 1 or phase 2, that's in the gut. After phase 1 and phase 2, liver dumps into the gut. And obviously taking a probiotic, your microbiome, that's like a whole nother hour of talking about that, how it helps you.
One thing I wanted to point out here is where you put avoid antibiotic, and this it really will be for all of those patients who actually call and say, I have a cold, I need something, I have a urinary tract infection, I need something. We try to look at antibiotic as, I had somebody who came in yesterday, 9 weeks of antibiotics for a cold. That's not a cold. If it was, that's not something that needed an antibiotic. So a lot of times before you ask for antibiotics, make sure you actually need it.
Right. I'm in favor of antibiotics for life-threatening situations, right? But for a common cold, you're right.
Yeah.
The other mineral supplements, magnesium, something that really fosters the Comt enzyme. So we like that. Selenium helps the thyroid. And then obviously, here's the other wrench. You could be doing everything right and have a good diet, but once you have insulin resistance, which could be genetic or could be, what you're eating, or could be because of cortisol issues.
Right.
And that's going to throw a wrench into everything. And that's one thing that I couldn't figure out. First, the bowel thing, like, why are these things not working for people's detoxification? And then it was the bowel thing. Or after that, why is it still not working? And in my case, it's been cortisol for the last 15 years. And I think, it finally was like, well, this is why I'm still stuck in this place, because of the cortisol issue.
Right.
So,
and the insulin resistance is actually a protective mechanism. The body resists the action of insulin because it feels it needs that energy. The glucose needs to stay out of the cell, so it stays in your blood. So really, we have to look at, like you said, the adrenal issue for people who are actually eating healthy. The stress has the same impact, whether it be emotional, physical, or chemical stress. Those are the stressors we are exposed to. They have the same impact as you eating a crappy diet.
Right. Very, very important. Yeah. And so some of it too with you and, with our Indian heritage, there's a high incidence of diabetes in Indian population. And I'm wondering if those genes that I don't know if you put those in the presentation, but those genes that you have, that actually I'd have to go back and look at mine to see if I have those as well, because I was pre-diabetic as well, even with a good diet and exercise. So that could be because of your heritage.
Yeah, I did mention 9 of my aunts and uncles were diabetics, and 4 of them died from complications of diabetes. My mother is a diabetic. So it's just, I know I don't want to go down that route. And the only way I can do is I have to constantly address all of those issues. And a lot of times, we have to bring this up also. Women tend to ignore symptoms because, you can continue to function. Some symptoms, like the genetic SNPs, some of them really get you down. Some of them will let you function at a normal pace, so you don't really look at it till it all comes tumbling down. So I think it's very important. And the only reason I did this test is I do have some symptoms, and I wanted to know my estrogen. I knew that was the only piece of the puzzle that I haven't addressed, because hormone is not my thing. So
That's a really, that's a really, really good point. I'm really glad that you said that, especially for all your patients that are listening, because as women, we need to buck it up, because if you are hormonal, then people think you're weak or you're crazy or whatever, in this, they look at it. It's not favorable, right? If you say you have a hormone issue. And so we internalize it, we'll get through it. And, the word on the street is still that don't take hormones, they cause cancer. People still think that, they don't understand because the media is not kind about it. So I think, in your case, my issue is people should know their genetics and they should know their hormone levels. So it's kind of like saving for retirement. You don't need to save for retirement, right?
Yeah.
No one's telling you you have to. It's just if you make a choice that you want to save for retirement so that you'll have an easier time and a better life when you retire. So it's the same thing as functional medicine. No one's telling you you have to do it. But if you want to be proactive about your health and learn about your genetics, your insulin metabolism, your hormone levels, then you're going to be proactive in your health and finding the root cause of symptoms.
Right. And then a lot of people, they accumulate it for years. And then when they meet the functional medical doctor, they're hoping that that one appointment will completely transform their lives. And this is why, look at this little screen, how complex it can get, but it can be simple if you go in a very systematic way and you just have the guidance. So, I mean, I could have easily done my own hormone, but I'm like, I'm going to get the best person I know for this. And that's why I'm here.
Yeah,
so,
I'm glad you did, because even though you weren't having a lot of symptoms of your menopause and perimenopause, that you're really lucky. So
right. I mean, I don't have any symptoms. It's just I have that one issue that I want to address, and I'm like, I know it's from my estrogen, so I'm glad it actually answered. And this is very interesting. The specific phytonutrients, I should mention, before I got my gut cleaned, I could not stand the taste of lemon or lime. I mean, I literally could not. And a lot of Indian, the food, part of it, the lemon pickle, and a lot of lime in a lot of our food. And I'm like, don't use lime and lemon. And now my husband always teases me. He says, we need to have a lemon tree in our home because that's how much lemon I use. It just shows how when your gut bacteria actually shifts, your taste buds shift. And I think I have now the bacteria that can really digest pectin and all of the citrus fruits, and I can actually tolerate them. I had it all through my childhood. I would not touch an orange of all the fruits. It's just very interesting.
Yeah, interesting.
So, all right, here's the area. This is the detoxification. I think we've beaten it to death, but I think these are the
one I want to point out here. Actually, there's a couple things that I want to point out here. So we've already gone over most of these, but the very first one at the top is 17A1A. That's also known as aromatase. Okay, so here's the kicker. That's the enzyme between testosterone and estrone, and DHEA and estradiol also. So I have seen this in people. Before we were able to test for this, I couldn't understand why their testosterone was always low and then their estrogen was high, or what was the source of estrogen, because they didn't have ovaries. How could they still have high estrogen? So you have a fast aromatase, which means your body wants to turn testosterone into estrogen, which isn't necessarily always good, because that's another pathway that's feeding estrogen, okay?
Right.
The second thing, you've got A1A, we talked about that. A1A is the one that is the good metabolite of estrogen metabolism, but then you have 1B1, you can see there, you've got a SNP at 1B1. So guess what? That's one pathway that your body will preferentially send estrogen, and it makes a metabolite called 4-methoxy. That particular metabolite can be really bad and go under a quinolone reaction and damage DNA and cause cancer. So instead of going that way, you want it to go towards the Comt, and guess what? Your Comt is slow.
Yes.
That's a big problem, that you're funneling it to 1B1 and then maybe not getting out of it. So for you, definitely, if you're not doing a lot of antioxidant, and Marina being a dietitian can help you with antioxidants. If you're, resveratrol and NAC is what I usually recommend for patients. You've got the absent GSTM1. So then, you know, that might be something that will help your body get rid of that toxic metabolite. So even just looking at, you know, your basic Comt and MTHFR, you can see is only a small piece of estrogen metabolism. So this test is great because I am not aware of many tests that has that 17A1 on it. And I think that's a very important piece to the puzzle as far as hormones.
So basically, not only am I not getting rid of my estrogen effectively, I'm also making a whole lot from nothing.
You're shunting it from other things into estrogen. Yeah. It's like you're the kid at school who's like saying, hey, come in here, let's smoke pot. And you're trying to grab everyone to go in this bathroom here and smoke pot and get everyone, even the good kids.
Yes. You're the bad influence here. Yeah, let's all go in. Yeah. So what happens when you put your genetics out there?
Right. So again, that's why I didn't know you sent me this before you even told me if you're having symptoms or no symptoms. So here, look at you. You weren't even really having any specific estrogen symptoms. So it's really lucky for you that you found this out, because we talked about following up with the Dutch test to really look and see to prevent breast cancer. So in my own little practice, when I test everybody with breast cancer, I would say over 90% have either a Comt mutation or one of the MTHFR. And if they have the 1B1 SNP that turns it up higher than, they're at more of a risk of not getting rid of the estrogen. And estrogen being something that stimulates growth of the breast and the uterus without the balancing progesterone.
Right. And after I got this done, I was looking at all the list of my patients who probably need to get this done. Yes. Because that's probably the missing link as to why we have to continue to monitor and try to figure out, hey, how do I reduce the risk for breast cancer? So this was very eye-opening.
Yeah, and your SALT one, can you go back 1 second?
Sure.
So your SALT 1-2, your SALT to the bottom, that you also had a heterozygote SNP that is associated with lower enzyme activity, higher BMI, and longer exposure to endogenous hormones. So you endogenously are turning all your hormones into estrogen. You're not getting rid of it. And the SALT is also, you're not deactivating it. So double whammy.
I'm all woman, man. I'm all woman. so it really,
honestly, that's why your skin and your hair look so good. You don't have wrinkles at all. You look a lot younger than you, because your estrogen is probably
maybe I don't want to mess around with this. Just let it be. I'll have it later. Yeah, I'll just have the breast cancer and just have long hair and good skin. All right.
These two we went over. Your SOD also has more to do with oxidative stress. So you had a homozygote SNP here. And so this would be more of a problem if you were a smoker, if you were using traditional hormone therapy that is oral synthetic estrogen. That with smoking would make you at increased risk for blood clots. With this SNP, this is your oxidative stress. We want to make sure that you're hitting the antioxidants either in the diet or that you're taking them.
Absolutely. Okay. So this is the summary of a lot of what you had mentioned. And what's interesting about this is weight management has been a lifelong challenge for me. And I think if I actually took my supplements, I might have a better chance as maintaining my weight with little less stress. And I'm terrible with my supplements, and I do admit to that. Saturated fats is very, very interesting. And with the craze of everybody going on a ketogenic diet, I did a podcast a week ago about ketogenic diet. So to do that, one of the things, and I think most physicians do that, I always experiment when I can with myself before I can say, okay, these are the things. And I can tell you honestly, 3 days of just doing fat, and I didn't do saturated fats, I did mostly fats, I was not well at the end of the third day. I felt swollen, I felt very uncomfortable. And as much as everybody believes the ketogenic diet is the next magic bullet, which is what we're all looking for, one of the biggest things is there are some people who absolutely don't do well, and this may be the answer. We don't process fats as well. I just can't do fats. And I've known that for a long, long time. That's why I always gravitated towards carbs. I'm not talking about the simple carbs, though I love simple carbs, but I do gravitate towards more of the vegetables. And exercise, I have to tell you about my exercise routine too. I have to do high intensity. I cannot be one of those that walks. I can walk for hours and not lose. I can actually gain weight. So it's really the high intensity, and it's so fascinating that your genes actually tell you, hey, what you've already known is already written in your genetic material.
But I think you had a couple SNPs, I think, that showed that you would respond well to weight training, right? Or did you have that on there?
I think so. I think I do have some. This is with a high,
like endurance athlete and elite.
Correct. I do have it here, but you know, I was never athletic. I would avoid anything. I have a high injury risk. I think somewhere here it comes.
Yes, yes. Okay, so these are the interesting ones too. I made some notes here. So we talked about the whole, is it the fact that you're Indian or, yeah, there's your athletic performance, right?
Yeah.
And then these last ones were the, I've heard people refer to them as the fat gene, the FTO, the ones, yeah.
The FTO is here, I think. Where is it here?
This is inflammation. So this one, the fat mass and obesity related. So you have just a hetero. So that's associated with a higher BMI. And so that might also be how you process fats, another reason why maybe you didn't feel good on keto. And so you have to restrict, your types of fats that you have decreased saturated fats. And and you, like you said, regular physical activity is recommended for you. You've got to do something 6 days a week.
Yes, I do. I actually would, if I do 7 days a week, I'm really good. And I think this was also high. This is my inflammatory.
This one was heterozygote as well. So moderately higher levels of CRP, which is, we think, the most sensitive inflammation for cardiac disease in women. So this is saying that you can't exercise high intensity too often in a row. But with you doing what you said was the high intensity interval training,
yes,
you are higher risk for injury. So the shorter bursts of energy is going to get you better metabolic effect without getting endurance. So if you were going to run a marathon and run the same pace the whole time and run for 2 hours a day rather than do 30 minutes of intervals, warm up, some intervals, cool down, you're going to have less risk injury and better metabolic. And you can, people sometimes figure that out intuitively. Like you said, you figured that out without
totally, yes.
So
I've just done this. I've worked with trainers and I just know I cannot sustain anything. I have to do interval training, and that's the only way. And it has to be pretty high intensity for me to get some results.
Yeah, that's interesting.
Yeah. And
these are all injury and collagen genes. And so that's why it puts you at a higher risk, because these are the collagens in soft tissue. One is for ligaments and tendons, and one is for soft tissue. And these put you at an increased risk of injury. And that's why when you had your overall summary, your risk was a little bit higher. So Correct. You're probably someone who wants to do, as you get older, balance things. Do you do yoga?
Yes.
Flexibility? Yes. So that's going to be really good balance as you are in the menopausal years and you're at risk for osteoporosis, because
right.
You're high risk. So strength training as well to make sure that your core is strengthened, and your muscle mass is good.
I know, and it's also, again, so intuitive. At some point I realized I needed to get into yoga, and this was something that it was a burning desire for me to do it as I've gotten older. And I can now, when I see the genes, and I'm like, Donna, just listen to that little voice.
Yeah, that's funny.
Yeah.
So these
All
are
right.
antioxidants again, and so I think these were the first one was normal, and these are greater aerobic performance. So they they have some that are fast twitch and slow twitch. So the one at the bottom, the PPR GC1A, is an increase of the slow twitch. This is saying that you personally have a better aerobic capacity, and that might be why you're able to tolerate the high intensity interval, because some people can't do that. You
can't
tolerate that high intensity,
Yeah. No, totally. I get it. And this was, I think, the final summary. And it doesn't look like I'm very powerful or I endure too much.
Yeah.
a few blocks. Yeah. So I was never athletic to begin with. And let me stop the share. So getting to, let me see if there's anybody who has any questions. Am I on the right space? I know a good, one of our clients just said, I know a good trainer, that her husband is a trainer.
It's interesting though, because we have clients who train, like running every single day, and they were actually highly inflamed. And when they switched it over to more flexibility and weights and stuff, they did a lot better.
Yeah.
So it's cool that it actually shows up in your genetics too.
Yeah, I'm gonna have to look at mine because I did this exact test last year, but I didn't pay as much attention as that as the methylation and the detox SNPs, and so I'm gonna have to pull mine out and see, because I am a runner, but I prefer to run like a 5K. I mean, I can run marathons and half marathons, but I'm a better, faster runner. So I like to do intervals and do speed rather than my friends that can just go run 20 miles all the time and it never bothers them. I'd rather go faster for shorter. So I'll have to see what mine is.
I know, it's awesome. And I think a lot of times how can we get this testing done? You can get it done in our office. So it's just a swab, and that's the interesting. It's a very simple test to do and give such a lot of information that you're looking for. And I think the key thing is, what do you do with the information? You got to do something with the information. It actually will transform how you're going to live your life in many ways, to optimize your good genes and to really curtail the ones that probably will put you at a higher risk for disease processes. So that's where the process comes. And it's like the liver slide that we showed, and I think we have that, is like so many steps to it, right? Those yellow slides that whichever one that was with, here we go. It's actually, we are looking at supplements, vitamins, the gut health, specific diet, as well as looking at your metabolic rate. I mean, there's so much it's not a question of just do the test and take the supplements. It's the whole process, the systematic approach. So for somebody who is really struggling with issues, what would you recommend this genomic analysis for everybody?
So that's a really good question. For anyone who has some of the issues that we talked about, like weight, any of the hormonal issues, the miscarriages like you have, fatigue, migraines is another really good one. The high blood pressure and the inflammation one, those are very helpful as well. I always think information is powerful. And so I've had some patients not want to know because they're afraid.
That's true.
Right. And so one of the things, and was April Wee was on here, and yours is
yeah, I'm 3-3. I'm good. Yeah.
I'm 3-4, so I have an increased risk of Alzheimer's, and I know there's people that don't really want to know. And so one of the things that I always tell people is about the agouti mice. So there was a study that was looking at mice, and they were brown. All of a sudden, they saw these yellow mice that were heavy and had diabetes, right? And they thought, well, the yellow fur wasn't causing them to have diabetes or to be obese. So they started changing their chow to have B vitamins in it. And so the yellow pregnant mice gave birth to brown,
silky
mice. Yes. And that's only with the B vitamins. So that's when you talked about all that yellow diagram with the supplements, the manipulation, the lifestyle. So having the genes, if you knew you had that risk, would you do something differently?
Correct. And I think that's the key message. I know people are scared. They say, I don't want to know, because I think the message that they received is, if you have a genetic trait, you are going to get it. And I think the message we're trying to convey here is, know your genes so you know how to handle and you can only choose to take what you want from your genetic information, not necessarily sit back and say, oh, I'm going to get it.
Right.
So my whole family on my husband's side, they all have the 4. And, it's a real struggle trying to get them to understand, you can actually change the trajectory of your health, your life, based on knowing your genes, because it'll tell you what exactly you should be, probably how you should be living your life to get the best out of it.
Yeah, so in answer to your question, I do think everybody should do it. I mean, the downside is it's not covered on your insurance, but it's not a test that you have to keep doing, right? You just do it the one time. Your genetics aren't going to change.
That's right.
Get the reading one time. It's an investment into your retirement per se, and you can make your decisions based on that.
It's probably good that insurance doesn't cover it in a sense too.
You don't want your insurance. You don't want your insurance to know your genetics. For number one, the most important thing. Can you imagine them basing their coverage based on what? Because once again, this is like the myth, right? I have the genes, therefore I will have the disease. That's a myth. And insurance is going to be very dogmatic about it. You have the 4 oh my God, this person is a high risk for Alzheimer's, no long-term care insurance for this person.
Right.
That would be, I tell people, be careful what you use your insurance for. Insurance is really to help you when you have a catastrophic event so that potentially you may not become bankrupt. It doesn't insure you to have great health. It doesn't insure you to have even good health. It really ensures, it's really the use of it is when you have that catastrophic event, you don't have to foot the $125,000 bill, just $30,000 is your share of it if you have the $30,000. So anyways, so this was awesome. Thank you so much, Tara, for actually reviewing this, because now it gives me, it was the that I needed to say, get on the Dawn supplements. It's not just simply about diet and exercise. I got to be taking my supplements, which I am terrible at, but now I will follow your recommendations, and thank you for the write-ups, because I will do, and maybe 6 months from now, I'll do a Dutch now and I'll do a Dutch later, and then we will see how I actually follow this intervention help.
That's a great idea. And I have a lot of those case studies on my patients too. I teach a course on how to do this. So I have the breast cancer patient with her urine metabolites through there based on, she didn't do the genetics right away. So, we saw like how do the detoxification support help, and then finally getting the genetics and helping that. So it's really fascinating, and it works. So,
and this is really about personalized and precision medicine. You just talk about, people want to come and they try different diets. I don't even know why they lose decades trying to tinker with something for which even those of us who work in this field have no clue, because there's so much to learn. And every time you learn something, it's outdated by the time you got to understand it and apply it in practice for about 6 months. It's like something new comes up. So I always, the biggest, I would say, a public service PSA would be, don't try to tinker with your own self. Reach out to a professional. And Tara's in actually Ohio, and I'm in Michigan. So reach out and we can do the task. We can actually help you and guide you through the transformation. And you may need it only for a short period, and after that you're on your own, because a good part of functional medicine is educating people to take care of themselves. I don't think any other profession, people are okay with having the same problem come back to them over and over again for years, right? Yes. So I think this is, we are in a age where you can actually get to the root cause. You can actually understand your risk, and therefore you can modify your whole health trajectory and look at your health span. This is not about lifespan. We're all going to die. I might, just walk out and on the icy roads be dead tomorrow morning. But what we are looking at, as long as you're living, let illness not be your barrier to achieving what you need to achieve in life. So is there anything else that you would advise? And we will, I guess we will schedule another meeting at some point after I do the intervention.
No, I think you're well said. And so I think a practice like yours that has personalized approach to medicine, you have your dietitian on staff who can personalize her recommendation based on these genetics and other things. So I think that's awesome. That's why, functional medicine is so great. So you're lucky to have you.
Thank you. And you've been awesome. I really appreciate it and appreciate your time.
Okay. Take care.
All right. Take care.
Bye-bye.